Okay, so medication choice. We love to pit medications against each other. The whole rock sucks things. There's t-shirts. It's great. Uh, I think that topic has been pretty well put to bed. Rocuronium and Sux are both great paralytics. Sux has some contraindications and some cautions we need to consider, but both medications are good. So a big debate that I'm sure there's t-shirts coming for is the etomidate versus ketamine. So we're going to talk about comparing our different induction agents. We're going to talk about the sequence in which we give them, and then we're going to talk about some dose variations and the evidence behind each of these. Okay, so ketamine versus etomidate. So this first trial is ketamine versus etomidate. It's randomized controlled. I think this is one of the higher quality ones. It's a couple of years old, 2022. So this trial is an ICU trial. So keep that in mind. So these are sick ICU patients. But the interesting thing about this trial is it has kind of mixed results. So the authors chose 7-day survival as their primary outcome. For what reason, I do not know, but they said, let's look at 7-day survival. So in patients who are given ketamine or etomidate, at 7 days, 85% of the ketamine patients survived and only 77% of the etomidate patients survived. But when you looked at peri-intubation cardiac arrest, well, etomidate was actually winning. So more patients in the ketamine group died right after they were intubated, but then were resuscitated. And then when you take this out to 28-day survival, it was a tie. So both of these medications overall, if you look right at the time of induction, etomidate did a little better. If you look a week out, it was ketamine that did better. But at the end of the day, a month out, survival was equal in both of these groups. So my take home is not that necessarily one is better than the other, but I think that they're both pretty reasonable medications. So that's 2022. Circle back a year later, a group did a meta-analysis. So again, a meta-analysis can be a very helpful way to look at a lot of trials, and they put them together. So they were looking at etomidate as an induction agent, but it wasn't one big control trial. They piled some together. So essentially, this graphic is showing they looked at etomidate versus any competitor. So basically, that was 1,300 of their patients. And then they looked at etomidate versus ketamine, and that was 1,200. So the etomidate group in both of these are pretty robust studies, but they took 11 different randomized control trials and piled them together. The cool thing about this is that it was pre-hospital ED and ICU studies. But there are some flaws to this. So just looking at this graphic, you can see that that any competitor versus etomidate actually had a little less mortality. So they had 23% mortality in both of the etomidate groups and about 19% mortality in the non-etomidate groups. But the problem is the endpoint for each study was different. So let's look at a little bit of some of the flaws we can see with a meta-analysis where they're grouping studies. So the endpoint was for survival, but it was different from each group. So some of these studies just asked 24-hour survival, and some of them asked 30 days survival. If you change the endpoint to 30 days in all of them, you had no statistical significance. So none of the medications changed. They were all equal. And about half of those studies of those 11 they included had some risk for bias. So that's something to think about if they weren't blinded or they weren't randomized or there was some sort of problem with them. So think about your meta-analysis it's a good quality of evidence, but if there's garbage in, then you get garbage out. So when etomidate was compared to all other agents, there actually was no difference at 30 days. So be careful when reading studies because sometimes the tagline of the study says one thing, but when you look at the data, you're like, actually, that's not really what this data is saying. So little food for thought on that one. My take home, both of these medications are good. Recent Twitter poll says that Twitter users prefer ketamine and Facebook users prefer etomidate. So I don't know if this is a generational thing, but just kind of a funny thing that was in 2022. So if there's a t-shirt to be had, you can pick one. But my big take home point is you can comb the literature. If you are team etomidate, you can comb the literature. You can find studies that say it's better for TBI, it's better for hypotension, it's better for sepsis, even. It's better for mortality. If you're team ketamine, you could do the same, right? You can comb the literature. If you're just looking for something that reinforces what you already think, you can find that answer. But when you really look at the literature as a whole, these are both very good medications. So I would not focus as much on which medication to pick, as I need to really resuscitate my patients. I need to oxygenate them. I need to dose these medications appropriately by weight, because both of these medications are much better than what we used to have, or we used to just give people Versed. Versed is definitely suboptimal compared to both of these agents. So if there's a t-shirt to be had, I'm still going to pick team etomidate, but I think that both medications are good. And, maybe that's just giving away something generationally, because I don't have Twitter or Facebook. So the other question that's asked then is, what about the dose? Does it matter how much I give? So classically, we've taught if someone's in shock already, and they're obtunded, especially, do we need to give them a full induction dose of either etomidate or ketamine? So will either of these change the incidence of hypotension? So does the dose matter? So this was a retrospective trial. So we're looking back on data. It's a ER registry data, a big one called NEAR. So 12,000 patients they looked at here. And they wanted to see who had risk of post-intubation hypotension, which they defined as less than 100 on the blood pressure. In the ketamine group, 29% of people had hypotension. In the etomidate group, 16 people had hypotension. Now, before you start getting rid of your ketamine t-shirts, let me just remind you this is observational data, which means they didn't control for ketamine or etomidate. The provider chose which one they liked. And definitely over the years, people have been taught that ketamine is more hemodynamically protective than etomidate because it often raises blood pressure. But what we know now is ketamine has a bit of a negative inotrope, and it only raises blood pressure by having the patient release their own endogenous catecholamines. So our patients who are in shock or who are septic have already blown through their catecholamines. So ketamine is still safe, but it's not protective. If I want to raise a blood pressure, I should give a vasopressor. I shouldn't pick ketamine because I think it's safer. So I think this is what happened in this group is the providers were picking ketamine more frequently in patients who were sicker because we had this bias and this teaching that, ketamine raises blood pressure. So the reality is neither of these medications is invincible for hypotension. Anything that sedates a patient can drop their blood pressure. So what we want to know is how much should we give of these? So there was a dosing range in these. We've taught classically half dose. Neither of these studies looked at half dose. So they looked back through the data. They looked at the weight of the patient and what was given. And in the etomidate group, it was about 0.2 to 0.3, which is actually the dosing range for etomidate. In the ketamine group, it was 1 to 2 milligrams per kilogram, which is actually the dosing range for ketamine in induction. So both of them were, if it was low end of the normal range or high end of the normal range, and neither one of these medications had a difference of dose. So if I gave 1 or 2 of ketamine, there was no difference in hypotension. If I gave 0.2 or 0.3 of etomidate, there was no difference. So we've been teaching classically to consider this half dose because we're like, hey, we don't want to drop people's blood pressure. But this study is it doesn't tell me a half dose doesn't help. It tells me a low end dose doesn't necessarily help. So my take home is, again, resuscitate patients well before you intubate them. If you're giving a medication, think about, is the patient completely obtunded and refractory hypotension? If that's the case, I'm probably not going to give a full induction dose. But a patient who I've resuscitated adequately, who's awake and looking at me, we should probably give them an adequate dose of sedative because we don't want them awake. We don't want them remembering. That leads me to my last topic before I promise to give you all a break. This study that came out in 2022 was the awareness with paralysis trial. So, the reason we give induction agents is to make the patient not experience pain, anxiety, not be awake when they're paralyzed. So, this was a prospective observational trial, which means they watched things as they recorded them. It was an ED study, so a little less than 400 patients. Uh, and of those patients, a little over 3% remembered being paralyzed. So, not that they remembered being intubated, but they woke up before the paralytic wore off. And so, it is not surprising that the majority of them received rock, right? Rock is long acting. So, 12 out of the 13 patients had got rock, and their sedative wore off before the rock wore off. And of those patients, they did, afterwards, they did a study like a PTSD risk score, and they had a higher risk of developing PTSD due to this event. So it is pretty important that not only we sedate people adequately to intubate them, but we resedate them. And if you're in the camp that rock rocks, then you have the T-shirt. Just remember, rock rocks, but it lasts a long time. So if I gave etomidate and rock as a combination, I need to be right on that post-intubation sedation. So confirm your tube, resuscitate your hemodynamics, and get that patient resedated. So this trial was, a small group. It was observational. It's definitely thought provoking. It should keep us in mind that we don't want our patients waking up. But spoiler alert, coming soon to a journal near you, 2025, they're doing an awareness with paralysis trial that's going to be much bigger. So much more protocolized. I think they may even randomize by paralytic. I'm not exactly sure, but this will be something to look at, some bigger evidence coming out. So wrapping up this first section on literature, big take homes. When it comes to pre-oxygenation, our patients are high risk. So 19% of EMS intubations are going to suffer desaturation. So anything that we can do to mitigate that risk by really good oxygenation is important. Know that chest injuries, high BMI, and peri-intubation hypoxia are big risks. BiPAP seems to be pretty promising. So even if my patient's a little out of it, BiPAP may pre-oxygenate and recruit more alveoli than your other methods of pre-oxygenation, even a flush right non-rebreather. So BiPAP definitely for refractory hypoxia, but maybe for everyone. We'll see. Resuscitate your patients well. In EMS, we're seeing about 3% rates of peri-intubation cardiac arrest. If you've been there, it does not feel good. If you have intubated 100 patients, you probably statistically, you've had 3 die on you, and you were probably surprised by this. So as best we can, we want to anticipate the risks. So hypotension, high shock index, peri-intubation hypoxia, and again, our obese patients and patients with anatomic difficulties are at risk. So really be aggressive about your resuscitation, use your vasopressors, give fluids when appropriate. And then lastly, as we're oxygenating and resuscitating, let's anticipate difficulty both anatomically and physically. If you are skilled at VL seems to be beating DL over and over again. If you're not skilled yet at video laryngoscopy, get that tool in your toolbox, because these devices are faster. They give us good success. And as you're training the next generation who doesn't get 50 tubes in their initial training, they're going to probably come out with a lot better skills with video than they are with direct. So be ready to pivot. Supraglottic versus ET tube and out of hospital cardiac arrest, no difference. Probably BVM as well. So run the call, resuscitate the patient, have your priorities, and manage the airway how you see fit. We're going to talk more about supraglottics in non-trauma patients, but so far with medications, remember etomidate, ketamine, both very good medications. Neither is perfect, so resuscitation is your take home. And for now, the jury is still out on the half dosing, but if my patient is completely obtunded and hemodynamically unstable, I'm probably not going to give them a full induction dose. I'm going to focus on resuscitating. All right. Here's my contact. We still have a couple more lectures after break here, but I just wanted you guys to have my contact if you want to reach out. And a couple of really good evidence-based medicine podcasts that I like. I would recommend Skeptic's Guide to Emergency Medicine. They do a lot of good EMS article review. And then the Airway World podcast. They do a quarterly webinar where you can get free CAPC credit.